Thank you, Guillermo. It was actually a much longer introduction than I anticipated. I wanted him just to tell you that I'm actually pleased to be here. I thank the organizers for inviting me. I am the president of NASPGHAN. This is an opportunity to reach out to Mexico, and I really appreciate all of you being here today. So this is my institution, which is in Cincinnati. That's where I work. And so let me tell you about my financial disclosures. Unfortunately or fortunately, I have financial disclosures, but they have nothing to do with this talk. I have an equity interesting company called Asclepion. We brought cholic acid or Cholbam to market for treatment of inborn errors of bile acid metabolism. It's now licensed to another company. We're not going to talk about that today at all. I have funding from several agencies. I also am a consultant to a number of companies, but none of these are relevant to my presentation today. Okay. So let me outline my presentation for you. Actually, you probably know that vitamin D interest has expanded quite remarkably over the last 10, 20 years. So I'm going to talk about that for a few minutes. The function of vitamin D, the Institute of Medicine report, which came out in 2010, vitamin D monitoring, vitamin D status in some selected GI diseases. I've chosen some myself. I wasn't directed to this, so I've chosen pancreatic and GI diseases, including IBD, because it's one we have a fair amount of evidence of the value of vitamin D. Celiac disease, EOE, which is the plague of everybody, I believe now. Biliary atresia, which I have a lot of experience with, NAFLD, and cystic fibrosis. And then I'm going to have a summary and some conclusions to give you a take-home message that's valuable from my talk. It doesn't look like many of you are wearing earphones, so most of you understand English pretty well. I'll try to be as slow as possible so it's not impossible to follow. Yes. So this is an interesting slide showing the number of publications by year on vitamin D, and you can see it's dramatically increased over the years from here way back in the 90s all the way to 2012. There's no concurrent. I put together this talk in 2015, and that was the slide that was available. Hadn't changed any, but I can tell you it's probably increased even since then. This is by country. You can see how many publications on vitamin D. So it's clearly huge interest. And the previous speaker alluded to the fact that vitamin D has an impact in obesity as well. So, and this is, at our institution, we measure 25-hydroxy-D. You know, that is the principal measure you should measure for sufficiency of vitamin D. Forget about all the other metabolites. Ignore them. As somebody says you should measure 125, please ignore them. Only pay attention to 25-hydroxy-D. The only current controversy that exists in vitamin D right now is, should we be measuring free vitamin D? And the problem with the current assay for free vitamin D, it's an ELISA that's marketed by a European company that, as best I can tell, has never been validated. So you have to be a little bit careful about that. So at the present state of the art, the 25-hydroxy-D measure is the measure of vitamin D sufficiency. And this just shows you at our institution the increased number of tests that are ordered for vitamin D at our institution over the last 15 or so years. Now, it's important to remember about vitamin D. Number one, there are two sources of vitamin D. One is the diet and one is the sunlight. Obviously, UVB irradiation gives you sunlight exposure, and you obviously, being at this latitude, have a fair amount of sunlight exposure, assuming you're not putting on blockers. The diet is the second obvious source of vitamin D, which typically is, fatty fish oil, liver oil, egg yolk, fortified food, specifically milk, and specifically other beverages. And then remember again, I put this in here to remember that 25-hydroxy-D is the measure of assessment, not 125. And I don't know what's measured in Mexico, but we measure vitamin D as nanograms per ml, not grams, nanograms per ml. You'll see it measured as micromoles per liter, but the correct measure, I'm sorry, nanomoles per liter, but the correct measurement should be, depending upon where you are, the goal should be for infants should be 20 nanograms per ml or 50 nanomoles per liter. And if you're an adolescent or older, 30 nanograms per ml and 75 nanomoles per liter. So the way that vitamin D is metabolized is very simple. It's metabolized by the liver. It's 25 hydroxylated in the liver. Thereafter, it goes to the kidney, and it's 1 hydroxylated, forming 125 dihydroxyvitamin D, which is the active metabolite. The kidney is really smart. It doesn't make too much 125, and will shunt it off to 2425 if it's making too much. So the photobiology of vitamin D is very basically simple. Vitamin D3 is made in the skin from 7-dehydroxycholesterol, which is converted to provitamin D. It's produced and then binds to vitamin D binding protein. And then here's the facts about photobiology. You can't overdose the vitamin D system with sunlight. You cannot. So you can get all the sunlight you want to. Now you can get skin cancer, but you can't overdose for vitamin D. You see decreased conversion of provitamin D with age. Sunscreens obviously inhibit photoproduction, and I'm going to show you that. And then there are seasonal variations, which you know. You probably don't have a lot of seasonal variations, but in North America, we have a fair amount of seasonal variations in vitamin D levels. So this is just showing you the cartoon of the conversion of 7-dehydrocholesterol to provitamin D to ultimately cholecalciferol, which is down here at the bottom. And then the binding to vitamin D binding protein. Well, that was great. That was not a good idea. I turned it off. And then, again, remember, the only source of vitamin D3 is from the sunlight. Okay? You can get vitamin D3 and you can get vitamin D2 from diet only. That's the only source it comes from. So you can endogenously make vitamin D3, or you can get it from the diet. So depending upon what the supplier of individual areas are, you may find vitamin D2 or vitamin D3 in the diet, depending upon cost as a supplier. So if you were to take an individual and give them a minimum erythemal dose of radiation of sunlight, which is shown here, this is the rise in vitamin D. This is the rise in vitamin D with that effect. If you put sunscreen on, you totally block it. And you know, in pediatrics, we're actually very sensitive about blocking sunlight exposure in infants, so they're probably not getting much from sunlight. The absorption of vitamin D, we're gastroenterologists. I think most of us are. We recognize that it requires micellar solubilization for absorption. That means you have to have an adequate amounts of bile acids in the lumen of the GI tract to form micelles that then solubilize water and soluble vitamin D into soluble forms. There's passive absorption across the duodenum and jejunum, and then it's transported in chylomicrons, and then it's bound to albumin and vitamin D binding protein in the sera. And remember, I alluded to the fact that there's a lot of interest in free vitamin D right now, but it's too early to actually jump on that bandwagon yet. So if you look at the absorption of vitamin D and vitamin D3, you can see they're virtually identical. So each one of them is absorbed about equivalently. And this is when you give a dose at the time point 0. And typically, if you give 50,000 units to an adult or 1,000 units per kilo, this is the kind of curve you get. And we've done work in this area in the past. Now, in contrast, this is an interesting point, and that is, if you look at the metabolism to the compound that we think is the most important one to measure in the sera, if you give D3, you see a sustained rise of 25-hydroxy-D after D3 administration, as opposed to D2 that declines over time. So it looks like the quality of what you get from the vitamin is better from D3 than from D2. So there's a myriad of metabolic transformations of vitamin D. There are 37 metabolites of vitamin D. You know, I just told you about 25-hydroxy-D, 125, and 24-25, but there's a whole bunch of other ones. And there are key enzymes that are related to these metabolites. The liver does the 25-hydroxylation, the kidney does the 1-hydroxylation as well as the 24-hydroxylation, and then regulation of this predominantly is by the kidney at the 1-alpha-hydroxylase. Now, why is vitamin D potentially important outside of the bone? Because of its paracrine function. That's why I put this circle around here. It actually has effects of vitamin D binding protein in lymphocytes and a variety of other tissues that we're now learning probably have impacts on the diseases that we treat. So let me talk to you a little bit about the Institute of Medicine report. Most of you know about this. It was a hellaciously long document. It was 1,000 pages. I did not read every page of it. I did read the summary statement, which was 4 pages, and I read brief parts of it. They reviewed evidence, and you can see on the side the evidence they used to decide on the strength of the evidence and the findings for the report. The conclusions from the report basically was that vitamin D and calcium play a key role in bone health. Guess what? I think we knew that already. Maybe it was actually a revelation to the reviewers. They recommended monitoring with 25-hydroxy-D, which is what I think most of us were doing. Again, the level at 20 nanograms per ml was chosen, and 50 nanomoles per liter were chosen as being sufficient for the IOM report. And they did not find that there was current evidence sufficient for other benefits. Now, that's because that was based upon the evidence that they had in this 1,000-page document. So this is important from a standpoint. One of the pieces from this document was basically they actually did a survey of levels, and these are in nanomoles per liter. Remember I told you 50 would be 20 nanograms per ml and 75 would be 30. And you can see by latitude what the winter and summer levels of these compounds are. Unfortunately, there's not one for Mexico City or Puebla, so I can't help you with what your peak and nadir is, but certainly there is clear differences that exist. The other thing I thought was really interesting from an N. Haynes report from the 2000s is the population frequency of vitamin D deficiency. And what they chose for this report was 40 nanomoles per liter. Remember, I told you 50 would be equivalent to 20 nanograms per ml. So this is about 17 nanograms per ml. But you can see for non-Hispanic whites, it's about 10%, with less than that. Non-Hispanic blacks, 50%, and for Mexican Americans, 27%. And then you can see the numbers for the values higher. If you apply the higher standards of 30 nanograms per ml or 75 nanomoles per liter, these numbers would be even higher. And it's important to remember that the distribution of these abnormalities, if you look at that, this shows you the levels of vitamin D, and the arrows show you the 20 and 30 nanograms per ml levels. And this is a series that we're in the IOM report showing for kids. You can see that the range here is in this range here between these numbers, and you can see the levels high and below. So there's a fraction. So I generally tell people, I think, for most Caucasians, the level of the percentage of deficit is about 20 to 30%, the general population. So you have to have that in context when you look at articles about GI diseases. So the Institute of Medicine made suggestions about dosing, which I'm not going to go through with you, but it actually suggested increases in dosing. It used to be 400 IUs per liter, 400 IUs per day, and the numbers you can see actually were increased fairly substantially by that report. And I have to actually throw in a little bit of a disclaimer because the Endocrine Society came up with different ideas about what was supposed to be normal, and they came up with the concept that it should be 30 nanograms per ml, and that was based upon the inflection at which you see a decline in the PTH level relative to the 25-hydroxy-D level. In adults like us, there's an inflection at 30 nanograms per ml. In kids, this is what the curve looks like. This is from 875 kids from multiple locations. There's no inflection in children. So generally, as I said, for infants and small children, I don't recommend going above 20 nanograms per ml as a required sufficiency. But for older kids, adolescents, beyond probably 10 to 12 years of age, I recommend having 30 nanograms per ml. Now, Let me skip that one. So let me talk about IBD for a minute. And this is actually two studies that are very interesting. These are both by Helen Papa, who was at Harvard when she did these studies, looking at kids with IBD, including Crohn's disease and ulcerative colitis. Their mean age was 15 years. You can see the mean 25-hydroxy-D level in this population was 20. 35% had levels below 15 nanograms per ml. 38% were Crohn's disease, and 25% ulcerative colitis, and 75%, three-quarters of them, were already on vitamin D supplements. So that means we're not giving these patients enough supplements. And they found that their reduced 25-hydroxy-D levels, were related to season, which everybody would recognize, but also to their serum albumin, which is probably a reflection of their active bowel disease. The second study that Helen did was this one, which was a larger study that included 448 patients. Again, the mean age was about 15. Again, the mean 25-hydroxy-D level was slightly higher, 31. And 58% were still less than 32 nanograms per ml, and 14 less than 20. Again, about 57% were supplemented, and again, the relationships were season, which is not unexpected, serum albumin, race, ethnicity, supplements, and their erythrocyte sedimentation rate. So those gives you some context about what we see in pediatric populations with IBD. So why is this important? Well, vitamin D plays importance in maintenance of the epithelial layer. This is sort of a cartoon showing that, innate immune response, as well as adaptive T-cell response. So it's not a big surprise that vitamin D would play some role in inflammatory bowel disease. Sort of the other surprise to me is that it doesn't seem to be that important for EOE, but there's very little literature about it. So the effect of vitamin D is predicted by vitamin D status and the risk of Crohn's disease, and I'm going to show you some articles about these effects. Serum vitamin D is related to QI in terms of having patients in remission. 25-hydroxy is related to surgical risk. And there's now a couple clinical trials in animal models and humans suggesting some value of D in Crohn's disease. The first of these, and this is impossible to read, so I'll walk you through it. These are two top and bottom, represent the lower quartiles to highest quartiles of 25-hydroxy-D. And what they basically tell you is that as you decrease your 25-hydroxy-D level, the higher your risk of having Crohn's disease. This is in a free population. There was a study that was done by Chip Sampson at our institution looking at 25-hydroxy-D levels by the percent of patients in remission, and you can see the relationship between remission, let me go back, between remission and their levels of 25-hydroxy-D. The higher their 25-hydroxy-D, the higher the frequency of sustained remission in Crohn's disease. There's also an article from adults demonstrating that the risk of surgery after previous surgery is reduced if you have higher 25-hydroxy-D levels. This is true for Crohn's disease, but not for ulcerative colitis. There's no data about this in children, but this is actually a good reference that you can look at. And then there's actually this trial looking at treatment of a group of adults with vitamin D, demonstrating that the top curve, which is an actuarial curve showing the number of patients in remission on D3 supplementation versus placebo. And you can see a difference between those, suggesting that there's some role for vitamin D in sustaining remission in patients. So here's the final comments I want to make about vitamin D and Crohn's disease. There is a biological plausibility for vitamin D's role in the pathogenesis of immune-related diseases such as IBD. It's also probably true for diabetes as well. There's no clear evidence of a direct relationship between vitamin D status and Crohn's disease course. And here are the current recommendations. And the significance of free versus bound 25-hydroxy-D currently is largely unknown, although you'll see literature about it emerging over the next several years. So what about vitamin D and celiac disease? Remember that many patients at diagnosis, we all know this, have reduced bone mass. The problem is, in part, is what was their vitamin D 2, 3, 4 years ago before they presented with their Crohn's disease. So all we have is data from the time that they present. And this is an article that was published in JPGN in 2014 looking at 25-hydroxy-D levels in 83 patients with celiac disease with a mean age of 13 years. And you can see that their median 25-hydroxy-D level was 32 with a range of 15 to 60, which means a fraction of these patients clearly had low vitamin D levels. But I'm not sure that you can attribute their bone disease to their low vitamin D levels. It's most likely other factors, including cytokines that circulate that have an impact on bone metabolism. Here's another article looking at, and this is an interesting point because of our previous speaker, looking at the level of 25-hydroxy-D level. And if you'll pay attention to the bar graphs below, you'll see these are normals versus patients with celiac disease. The green ones are obese versus non-obese. So you can see the numbers don't look all that different, but certainly with obese patients, their levels tend to be lower. And then this is an article that was an interesting one from that came from looking at kids with celiac disease versus children with recurrent abdominal pain, the bane of our existence. Nobody's laughing. And then patients who had Crohn's disease as adults from Spain versus Crohn's disease in children. And the bottom bar graph represents there the percentage of patients with levels less than 20. And you can see from Spain, for some reason, their level was the lowest of all of them. But you can see that there is a fraction here of all these that have reduced 25-hydroxy-D levels. So this is a patient population we should pay attention to and make sure we're giving adequate supplementation to. What about AAP guidelines? AAP guidelines recommend measuring 25-hydroxy-D levels and following up if they're abnormal. It's based upon very, very weak evidence. Okay, what about vitamin D in EOE? Okay, well, there's almost no literature. The reason there isn't any literature is I don't know. But I can tell you this is an article that is ahead of print in JPGN 2017, and what you find here is the patients with GERD versus EOE have virtually identical 25-hydroxy-D levels. So this article is interesting because the next slide is quite interesting, and if you look at this slide here, this is the relationship between the vitamin D level and the number of eosinophils in the mucosa, in the esophagus. What do you expect to find? Well, you'd expect to hopefully find some kind of inverse relationship. Guess what? What you find is a direct relationship. So it looks like there probably isn't much role, at least in this particular population of patients, for vitamin D and EOE. That doesn't say you're supposed to ignore vitamin D and EOE. I'm just telling you it doesn't appear to have a direct relationship. A topic that I think has been one that has been a struggle for us for years has been 25-hydroxy-D levels in cholestasis. And we know that kids with biliary atresia not uncommonly have reduced 25-hydroxy-D levels, and this is actually from the children's study, which is a study we participate nationwide in the United States. And you can see the levels at 1 month, 3 months, and 6 months are increasing. And again, remember, this 20 is probably sufficient. The interesting thing is this looks promising, but if you then look at the 25-hydroxy levels here, which is after Kasai, and then if you look at this particular graph, this is the most telling of the graphs. The more cholestatic you are, the lower your 25-hydroxy-D level is, which is exactly what you would expect. So the percentage of patients with cholestasis post Kasai that don't have a successful Kasai, they're a population that are at risk for fairly profound vitamin D deficiency. So for NAFLD, there is some data suggesting that there may be some benefit for 25-hydroxy-D levels. These are just showing you the levels from a meta-analysis. And then there's been some trials demonstrating that with supplementation, 25-hydroxy-D increased, serum levels of ALT and AST improved, but there was no change in any of the biochemical markers, and these didn't include histologic changes looking at these. And then finally, CF. We all know that CF is a difficult disease to treat in terms of their vitamin D status because they obviously have pancreatic insufficiency. In the best of circumstances, they still are not as good as you would hope. And here are patients with CF versus healthy controls, again showing this difference, and you can see the discrepancy by the bar graphs on the right. And then finally, if you look at patients that have CF in a more recent study from 2014, again, this shows you deficient, sufficient, or insufficient, sufficient. You can see the fractions continue to be present in these populations. So here are the conclusions from my talk. Number one, I didn't talk anything about supplementation, which I apologize about. But for diseases, it's important to remember if you're shooting for a normal 25-hydroxy-D level, as long as you're monitoring vitamin D levels, you can give all the vitamin D that you want. If you don't monitor them, then you can get into trouble. So as an example, children with biliary atresia, which are the hardest of our patients to treat, sometimes require 1,000 to 2,000 units per kilo to get their vitamin D levels into the normal range. So it's important, just remember, as long as you're monitoring and you're keeping track of this, you can give as much as you want to. And you can give STAS therapy, you can give 50,000 unit shots, you can give 1,000 units a day or 2,000 units a day, you can give 50,000 units a week. As long as you're monitoring them, you will not get into trouble. That's the take-home message. Okay, so reduced bone mass in GI, hepatobiliary, and pancreatic disease secondary to combination of factors. It's not just vitamin D. It usually is circulating cytokines, IGF-1, and other factors that actually influence their bone mass. Supplement vitamin D levels commonly reduce but do not necessarily cause reduced bone mass. Vitamin D may play an important role in the pathogenesis of inflammatory disorders like IBD. And it's important, this is my take-home message to you, monitor and maintain adequate serum levels with supplements to optimize therapy, and you can give all the vitamin D you want to as long as you're paying attention to their levels. And I thank you for your attention very much.